Right, perhaps let me start my talk with this survey that we published 1 year ago. And this survey found so that amongst those private obstetricians who do anti-screening in Hong Kong, only less than half of them will have accreditation, right? And only 1/3 of them will send to a laboratory which is doing external laboratory control, right? So you can see the quality assurance is not very good. Now, I'll give you a real bad example, right? This patient have a screening in a private doctor's, right, and was told to be screened positive, and then come to my unit, right? And this is the photos that was taken by her private doctor, and this is the measurement of the quantum length, right? And you can see that, right, the measurement is not good, it's not magnified, and the quantum length is 4 centimeter, and which is not the size that we should measure the NT. And this is the photo of the NT measurement, right? It's again not maximized, and you barely see that the caliper is putting here. And the first measurement is 0.12 millimeter, right? This is the second measurement. Again, these two pictures look very similar, but the measurement is 0.23 millimeter, right? It's double, even though both pictures look very similar, right? So it is far away from what we want as a standard measurement. Now, in that case, if you have a friend, right, how would you advise her, right, to which doctors she should consult for the screening? Or as a service provider, how should we monitor our quality, right? Of course, right, the simple answer is consult the expert, trust the expert, right? And I'm sure that Professor Kypriadis is the expert in this field, but not all of them can go to UK and then ask for his help, right? So how can we define the expert? Right? Ask the senior doctor to do it, right? I'm not sure whether the senior doctors could do this better than the junior doctors, right? If I have an appendicitis, I need an appendectomy, I will probably ask a middle grade doctor instead of a senior doctor to do it for me, because usually the seniors are away from the clinical. Right? Should we ask those, should we define the expert by their publications, right? Again, I'm not sure, because although they study a lot, publish a lot, but in a real clinic setting, a service setting, which is far away from the study setting, right? So the quality may not be the same, right? The expert is those who teach a lot. That I am really not sure, right? Somebody is just taught but not do, right? I attended a meeting and found that one of the speakers actually saw an anti-measurement which is suboptimal. Have you had this experience? So, should we ask the ones who do a lot, right? Those who do a lot should be more experienced, right? Again, in our private doctor setting in Hong Kong, right, they do a lot of NT, they have a lot of patients, but they only can spend 5 minutes for one scan, right? Can you ensure the quality, right? So the only way is that we have an objective proof of our performance. Right? Then you may say, right, we should all get the UK FMF accreditations, right? So I also get the accreditation, and how many of you have the accreditation? Raise your hands, right? So is it difficult to get accreditation? No, because you only submit 3 images, and I'm sure that you will select the best 3 images for the submission, right? Is it easy? Yes, right? So if you pass the accreditation, it just means that, right, you have the adequate knowledge, you have the adequate skill, right, for the scanning. But it doesn't mean that you do the same, you do it perfectly in real situation. But of course, right, if you fail this accreditation, certainly it means that you have no knowledge, you have no skill and also no insight. Now, so having accreditation doesn't mean that you compile all the time, right? Because there's time constraint and the fetus may lie in a suboptimal position. It's just getting a driving license. You got a license, you are allowed to drive, but doesn't mean that you could drive safely, right? So how can we know your performance, right? We will know that you are not driving safely and, when you have a traffic accident, right? That's why we have to know your sensitivity and false positive rate where you got an accident, right? So may I ask, in your centers, are you doing screening for more than 1,000 a year? Raise your hand. More than 1,000 a year? No. How many of you are doing 2,000 a year? Not only you, your center. Right? So how many of you know the sensitivity and false positive rate of your center? Nobody. Right? So this is the reality. How can you tell your patients that you got a good quality? Now, let me show you, illustrate the points by my publication 209. Now, in this paper, we have screened 10,000 cases. The screen positive rate is 6%, and the false positive rate is about 5%, and our detection rate is 90%. So we follow up what we have done, right, and come out these figures, right? To know the false positive rate is easy because for those who are screen positive, we'll advise for a CVS or amniocentesis, right? And then you know the karyotypings, and then you can know the false positive rate, right? It's easy. But to know the sensitivity, whether it's up to standard, is difficult because the overall preference for Down syndrome is still low, right? For example, in our 10,000 cases, we only have 34 cases of Downs, right? And the overall preference is 0.3%, right? And therefore, if you want to show that the sensitivity in a unit is substandard, that is from 90% decreased to 70%, you need a large amount of cases before you can confidently say that it is substandard, right? So you probably, in your unit, you probably do 3 or 4 years at least before you find that your unit is poor. So, and also your poor NT measurements may be masked by a good biochemical testing, right? And therefore, the sensitivity, right, if you are doing NT unknown, will be very poor. But because you are good biochemical screening, right, that sensitivity is compensated. And also, there's a time gap between your scanning and outcome, right? You scan it at 12 weeks, and the baby will deliver at 40 weeks, which is 6 or 7 months later before you know that you miss a case. And finally, follow-up is essential, right, to know whether you miss a case or not, right? And it's quite often the follow-up is complete, especially in mainland China. I understand that. Right? And therefore, we can't assess the quality by looking at the sensitivity of false positive rate alone, right? We have to look at the distribution of your NT measurement, right? And from the visual judgment, you know that you can see that, well, for Dr. A, the distribution is quite okay because most of the measurement is within this range, right? For Dr. B, you find that it's probably under-measured, right? But you know that, right, the normal range, right, varies with gestation, and therefore we have to correct by using a gestation-specific multiple of median, or we call it MOM or MOM, or delta NT, right? And after correcting it, you have this distribution curve, right? And if you are good enough and you have done enough, more enough, then your distribution should look like a normal distribution, right? And you have a median in the middle. This is not a very good one, right? So you have median and fifth centile and 95th centile, right? And this distribution curve is very important, right? Because it will tell us whether you have under-measured or over-measured, right? And John Hyde has shown you this chart before, and you can see that, right? This is the deviation of the NT measurement, and this is the detection rate. And this line is the performance by doing NT alone, and this line is the performance with a combined screening. Now, just look at this line. If your measurement deviate or under-measured by just 0.2 millimeter, 0.2 millimeter, the detection rate already dropped from 95% to 68%, right? And if you over-measure it by 0.2 millimeter, right, then your detection rate also increased from 73% to 78%. Then you will say, wow, good, we have a higher sensitivity, right, by over-measuring, right? But the cost is you also have a higher false positive rate, right, from the original 3% to 5%, right? So looking at the distribution curve is very helpful, right? But it's still not enough, right? Because there is also a variation in the dispersion, or we call it a standard deviation, right? So in this case, you have a wide SD. In this case, you have a narrow SD. And it also affects the performance, as illustrated in this chart. Now, so if the SD, right, increase from 1 to 1.2, the detection rate slightly reduced, right? And if this and if the SD increase from 1 to 1.2, the false positive rate, right, also increase, right, from 3% to 4%, right? And therefore, we should not only monitor your median or the central tendency, we should also monitor the dispersion by looking at the NT-MOM SD, right? And therefore, we divide this picture, right, these figures, right, to illustrate, right? So the x-axis is the measurement of the central tendency. The y-axis is the measurement of the dispersion, and 1 is perfect, right? 0.1 is also the median, is perfect. Now with the median NT-MOM is about 5% plus or minus 5%, and the dispersion is plus or minus 20%, then it is a very good performance. But if it is within the larger yellow box, that is the MOM range from plus or minus 10%, and the dispersion is plus or minus 25%, then it is acceptable, right? So for this one, it's a good performance. It's within the smaller box, and this one is acceptable. But for this one, it's too bad, right? Because it's over-measured, right? But the dispersion is still within the acceptable range, right? For this one, it's over-measured and the dispersion is too wide, right? This is unacceptable, right? So by looking at this, right, we can know how good is the ultrasonographer. But that is still not good enough, right? We want to pick up the deviation as early as possible. We want to pick up the poorly performed sonographer as early as possible, so that, right, we will not jeopardize the whole screening program, and we can also retrain the sonographer earlier now. And therefore, we have to use this cumulative sum chart, right? We call this Q-sum, right? So this is a prospective assessment, and the deviation of each measurement will be count and accumulate, right? So that, right, the alarm will raise up, right, if the Q-sum score cross the preset limit, right? So for example, now this is the performance of one of the sonographer, right? So the deviation all along is minimal, and therefore is always within the limit, right? But for this sonographer, he always underestimate, and therefore, right, the score is negative, and because they're accumulating, therefore this score become more negative and negative, right? And for the third sonographer, is similar, but he tends to overestimate. And for the fourth sonographer, the initial performance is quite okay, but then after 150 cases, he starts to overestimate. Right? So by looking at this chart, we can pick up the deviation earlier as, let's say, after 50 cases or after 1 case of measurement. Right? So by doing so, we allow an early detection, right, so that we can retrain the sonographer. Right? So in Hong Kong, the government started the universal first trimester screening since July last year. Right? You carry out in all 8 public obstetric units in Hong Kong, and our university receives biochemical blood sample from 4 of the units, right? And we are responsible for the risk calculation as well as to carry a regular auditing and reporting and feedback to those units. And here you can see the result of the 4 centers, and you can see that Center D is doing very well. Center B, not too bad, it's okay. And Center A initially is overestimated, but then after correction, it's turned to normal. But then Center C, right, overestimated NT, right? So actually, we should, right, have warned the center at this moment, right, to before it's going too far away. Now, and we also generate reports, right, showing their distribution curve and the central tendency and dispersion box, and also the overall median of measurement every week, right? So I think after the today sections, you understand how to measure NT, but also understand the importance of quality control, right? And we must have an objective assessment of the performance. Training and accreditation is essential, but not sufficient. And regular monitoring of the central tendency as well as the dispersion is important. And a cumulative sum chart allows early detection of the deviation and also allow early feedback and retraining. And lastly, complete follow-up of all the outcomes of missing case is essential, right, for review. Thank you very much.